Hello guys, I am Dr. Gundesh and today we are going to discuss about hypokalemia in depth because serum potassium estimation is a routine investigation that we'll be doing in almost all the patients. So whenever you find hypokalemia, you should be confident enough to evaluate the case confidently. So about hypokalemia, we'll be learning about the normal levels, clinical manifestations and evaluation part and the treatment part in both acute and chronic settings. So the normal level of serum potassium are 3.5 to 5 milliequivalents per liter. So if there is any decrease in potassium levels that is less than 3.5 milliequivalents per liter, you will find clinical manifestations. These clinical manifestations are more evident when the potassium levels is less than 2.7 milliequivalents per liter. So the clinical manifestations of hypokalemia are: hypokalemia affects muscles and kidney mainly. First we'll study about how hypokalemia affects muscles. So in muscles, hypokalemia causes decrease in excitability in both skeletal and smooth muscles, but in cardiac muscle it increases the excitability. So because decrease in excitability in skeletal muscle and smooth muscle, you will get to see acute intermittent paralysis because there will be decreased excitability in skeletal muscle, and because of decreased excitability in smooth muscle you will get to see paralytic ileus. So in severe cases you will also get to see rhabdomyolysis. And because of increased excitability of cardiac muscle in case of hypokalemia, you will get to see tachycardia in case of hypokalemia. So those tachyarrhythmias include atrial fibrillation, ventricular fibrillation, atrial and ventricular tachycardias, and also junctional tachycardias. And there are some typical ECG findings that you can see in a case of hypokalemia. The first one being broad and flat T waves and prominent U waves and a depressed ST segment, and the last one QT prolongation. So if in any case of pre-existent QT prolongation, if the patient goes into hypokalemia, then there is a increased chance of developing torsades de pointes because of QT prolongation. So these are the manifestations of hypokalemia affecting muscles. So the second one is hypokalemia affecting kidney. In kidney, it causes nephrogenic diabetes insipidus. That is, hypokalemia causes nephrogenic diabetes insipidus because it causes resistance of ADH receptors in collecting duct. So that is why there will be polyuria. And in hypokalemia, there will be retention of sodium, chloride and bicarbonate, and there will also be hypocitraturia. But there will be increased excretion of phosphate. That is why you will get to see phosphaturia. So these are the manifestations of hypokalemia affecting kidney. So whenever you find these clinical manifestations, you should evaluate the hypokalemia properly. When you diagnose this case as a hypokalemia, first you will ask about history of any drug intake. The drug intake include the diuretics mainly. So diuretics cause hypokalemia in the long run. And you should also ask about a history of drugs which act as a non-absorbable anions in the nephron. That's why as these drugs act as an anion, these drugs will pull the potassium with them through urine. So that's why these drugs cause hypokalemia. So these drugs can be remembered with the mnemonic that is not drug of choice. N means nafacillin, T means ticarcillin, D means dicloxacillin, O means oxacillin, C means carbenzylin. So these 5 drugs will act as a non-absorbable anions. That's why they cause hypokalemia. So the 2 drug history that you should ask is diuretics, and the second one is non-absorbable anions. And the second history that you should ask about is diarrhea or vomiting. So in both diarrhea and vomiting, you will get to see hypokalemia. So once you start evaluating, the first investigation that you should do is serum magnesium levels. So the first investigation that you should do is serum magnesium levels, because normally magnesium causes decreased excretion of potassium through renal outer medullary potassium channels, that is ROMK, in collecting duct. So when there is decrease in magnesium levels in serum, there will be no inhibition of potassium excretion. That's why in a case of hypomagnesemia associated with hypokalemia, first you should replace magnesium levels. So once you replace magnesium levels, patient will respond properly to the potassium replacement in a case of hypokalemia plus hypomagnesemia. So there are some set of drugs which cause both hypomagnesemia and hypokalemia. Those drugs are cisplatin, aminoglycoside, amphotericin B, and foscarnet, and the last one ifosfamide. So the first investigation that you should do in a case of hypokalemia is serum magnesemia. And the next step is you should classify the cases of hypokalemia into 2 groups, that is non-renal loss hypokalemia and renal loss hypokalemia. So that's why the second investigation that you should do is the ratio of urine spot potassium to creatinine. If this ratio is more than 13, then it is a case of renal loss hypokalemia. If it is less than 13, then it is a case of non-renal loss hypokalemia. And instead of this ratio, you can also do a single test, that is urine spot potassium. If urine spot potassium is more than 15 milliequivalents per liter, then also it is a case of renal loss hypokalemia. If it is less than 15 milliequivalents per liter, then it is a case of non-renal loss hypokalemia. So once you segregate the cases as renal loss hypokalemia and non-renal loss hypokalemia, you should evaluate further to find out the specific causes. So in case of non-renal loss hypokalemia, the first thing that you should do is ABG, that is arterial blood gas analysis. If in that cases, if you find normal anion gap metabolic acidosis, then it is a case of diarrhea, that is diarrhea causing hypokalemia. If you find out NAGMA, that is normal anion gap metabolic acidosis. If you find ABG to be normal, then it is a case of redistribution causing hypokalemia, that is the potassium is being shifted from serum to intracellular area. That is why in serum you are finding hypokalemia. So there are set of causes which cause redistribution of potassium leading to hypokalemia. So these set of causes can be remembered as Sheethal's bag. So in a funny way, you can also remember it as all the potassium is going to Sheethal's bag. That is why the potassium levels are low. So S for sympathetic activity alteration, and H for hypokalemic periodic paralysis, and I for insulin, T for thyroid hormones, that is excessive thyroid hormones, and AL means metabolic alkalosis, and the last bag means beta to agonistic activity, and the opposite of that alpha antagonistic activity. So these set of causes cause redistribution of potassium from serum to intracellular area will lead to hypokalemia. So this is how you evaluate a case of non-renal loss hypokalemia. If you find a case as a renal loss hypokalemia, then also the first investigation that you should do is ABG. There if you find a metabolic acidosis, then it is a case of renal tubular acidosis type 1 and type 2, not renal tubular acidosis type 4, not RTA type 4. In RTA type 4 you will get hyperkalemia, not hypokalemia. So in only RTA type 1 and type 2 you will get to see hypokalemia. So if you find alkalosis in a case of renal loss hypokalemia, then the next investigation is measurement of blood pressure. If you find high blood pressure, that is one group. If you find normal or low blood pressure, that is one group. So if you find out high blood pressure, the next step is measurement of plasma aldosterone and renin activity. So in here, if you find increased aldosterone levels, then it is a case of either Conn syndrome, Cushing syndrome, or glucocorticoid remediable aldosteronism, and can also be congenital adrenal hyperplasia if the patient is young and if you diagnose it properly. And if you find the aldosterone levels are low, then it is a case of Liddle syndrome or syndrome of apparent mineralocorticoid excess. This is how you evaluate a case if you find out increased BP in a case of alkalosis. So if there is a decreased BP or normal BP, then the next step is the measurement of urine chloride. So if the urine chloride levels are less, then it is a case of vomiting leading to hypokalemia. Because of vomiting, there will be loss of hydrochloric acid. That is why the chlorine is being excreted in a lesser amounts in urine. So vomiting as a cause of hypokalemia. If you find increased chloride levels, then it is a case of Bartter syndrome or Gitelman syndrome. And one more thing is diuretics. In early stage of diuretics, urinary excretion of chloride is high, and in the later stages, if you use the diuretics for the longer time, then also it causes hypokalemia, but urine chloride levels will be low. So this is how you evaluate a case of hypokalemia. And the next thing is treatment of hypokalemia. So in acute settings, you should give potassium chloride solution, that is 2 ampules of potassium chloride solution in a 200 ml of NS over 2 hours. So this is a standard method that we use to correct hypokalemia in a case of acute settings. And maximum you can give 2 ampules of potassium chloride per hour, and in a day you can give up to 16 ampules of potassium chloride per day. So if the patient is not showing any symptoms or signs of hypokalemia. So this is how you treat a case of hypokalemia in acute settings. If it is a chronic setting or for the maintenance dose, we will give potassium citrate solution or potassium chloride tablets. In a case of renal tubular acidosis type 1 and type 2, you may need to replace the bicarbonate levels. For that, you should give Scholl solution to replace the bicarbonate levels. So this is how you diagnose, evaluate and treat the case of hypokalemia. Thank you.